Hello and welcome to the Safety and Quality Education Program podcast. Developed by Metro North Health Safety and Quality in partnership with the Clinical Skills Development Service. Metro North Health acknowledges the traditional custodians of the land upon we live, work and walk, and pay our respects to elders past, present and emerging. The Safety and Quality Education Program has been designed with a focus on patient safety improvement. Each episode will explore ideas and stories in making our care delivery safer for our patients through the implementation of short notice accreditation. Our host is Dr. Mia McLanders, who is the Manager of Research at Clinical Skills Development Service. Mia is an applied researcher with a background in human factors and cognitive psychology. Joining Mia on this episode from Metro North Health is Dr. Liz Rushbrook and Pauline Walter. Dr. Liz Rushbrook is the Chief Medical Officer, Medical Services of Metro North, and chairs the Metro North Standard 7 Committee. Liz is passionate about all aspects of blood management, with experience in enabling blood products to be deployed to forward military care through to promoting and maximising effective use of patients' own blood. Pauline Walter is a consumer representative on the Metro North Standard 7 Committee. Pauline has been on kidney collaborate groups for about 6 years. Her interest in blood management was when she needed transfusion after a surgery, which led to her transplant being rejected and removed within 10 days. In this episode, our guests explore safe blood management.
Liz, tell me a little bit about your background.
So things that most people, I'm originally from Queensland, and that might sound a bit funny, but I then joined the Navy as a medical student, and so I finished my med school here in Queensland and then went down to do Navy training and then spent 25 years away from Queensland, all over Southeast Asia, Southwest Pacific and almost every state in Australia that I worked in. And so we came back in 2016 to move back to Queensland. My family came back. We came back to look after my husband's mother. And so I left the Navy at that point and moved to Queensland Health, and I've been here ever since.
Do you miss the Navy?
Not at all. Loved it. Loved every bit of it. In fact, if that's really some of the thing that has made me love blood and blood products. So if you know anything about me, that as a doctor in the Navy, we were also always very, very involved in trauma and trauma care. And for blood and blood products, the logistics of getting fresh blood or blood products to a trauma environment in the military is incredibly challenging, particularly when you're going in areas of operation where you don't have your normal delivery dates and or fridges or freezers, and then the logistics of having to cycle out that every 6 weeks, because really the shelf life of red blood cells is 8 weeks. And was a really big challenge. So in Afghanistan, we learn a lot about trauma and trauma care and the availability and using technology that the US and the Netherlands was using at the time. And they were freezing at very, very very, very low temperatures, blood and blood products, taking the shelf life from 8 weeks for packed red cells to 2 years.
Wow.
So really quite extraordinary. Wow. And taking plasma, frozen plasma is a thing, but deep frozen plasma is an even bigger thing. And it was taking the shelf life from 2 years to 8 to 10 years as well. 8 to 10 years, and then platelets. Platelets has, if most people won't know, has a shelf life of 5 days. Wow. Okay. And you could deep freeze platelets to get 2 years out of that, which is enormous. Now, I'm talking not small trauma. These are big traumas where you end up with double and triple amputations, really significant IED traumas that we were needing large amounts of blood and blood products for. And it just revolutionised the way we responded to that kind of trauma in the battlefield.
It must be heartbreaking when you see the wastage of blood products.
Oh, Absolutely. But for me, even that, 6-week cycle was devastating, because you would get to the end of the 6-week cycle and be returning blood and blood products that couldn't then be used because you'd exhaust them in the field. But in fact, a lot of the time we were able to cycle them into, if we were in third world countries, so we would cycle them into third world countries to be able to be used at that time, because in some of Southeast Asia and Southwest Pacific, blood and blood products were so rare that they would be used up within an hour of arriving at a hospital. So completely different. But the exciting thing is now, like, the standards over blood and blood product standards have changed over really the past 5 to 10 years significantly as they were developed, from good governance of blood products, because there was an assumption that they just were, whereas now it's about the personalisation of blood and blood products, so that the blood and blood products belong to people. We want to make sure they don't lose the blood to start with, and that's an important part of this standard, that we optimise people's blood. We make sure that they don't or won't lose the blood, or if they're going to lose any blood, that they are in such a condition that they can afford to lose a little bit of blood without then relying on somebody else's blood products. So, and I think that's the best thing that's happened out of this standard in the last 5 years.
That's fantastic. Pauline, what are your thoughts? What's your experience with this standard with blood products management?
My first experience was waking up after surgery for a strangulated hernia and bowel resection to be told, we're going to give you blood. And I was on the transplant list at the time for a kidney, and I looked at them and said, I can't have blood. It's going to spoil my chance to get a successful transplant. And they said, no, you need 3 bags of blood. You either get the blood or you have a heart attack.
Wow.
And it was I was traumatised, so I was crying, and I just went, okay. But, since then, I've learnt more about it. I've seen the changes in the way doctors now approach people when they need blood transfusions. It's much more informative and explained much better. And so it was, it's not quite so scary anymore.
Liz, when you're you're obviously very passionate about this standard. Is it your time in the Navy that you really refer to when you're thinking about real people having real consequences for the mismanagement?
Look, I think so, because really, as a junior doctor, as like any junior doctor, you're just going about your business, and often it wouldn't be your idea or your diagnosis to give people blood. It would come from your consultants. And as a junior doctor, my job was just to tell people that they have been recommended to get blood, and then need to answer the questions that people had. And so I didn't really think about it much as a junior doctor in relation to what my roles and responsibilities were in informing people about the reasons why they might need blood, about the choices that they had and the consequences of those choices. I think the information available now is amazing to all clinicians, so that we can be part of the conversation with the people who might be recommended to get blood and or blood products. And I'm now much more aware of the chronic need that some people have for blood and blood products as well. So it's not just sexy trauma that might require, or post-surgery that might require blood or blood products, but there's a lot of chronic conditions and people that are really reliant on these products. So they're so precious. I've been involved so many times when there's been shortages over the years that you need to be treating these products like gold and ensuring that they get to the people that need them at any time of the day.
What's the difference between a clinical area that has good blood product management versus poor blood product, like from a consumer point of view, Pauline, but also particularly from a doctor point of view, Liz? How do we tell the difference? When you walk into a clinical environment, can you tell immediately the difference?
Usually it's staff attitude to what's going on, I find. If you've got staff that are really on the ball, they know who you are, they know why you're there, they'll sit and talk to you, they'll explain what's going to happen, whereas others, you just come in, sit down, get started. There's no real conversation around what's happening.
That's interesting. And just from that interaction, that first interaction, you can tell, Pauline, the difference in how they're going to manage your blood products. That's so interesting. And Liz, from your point of view?
You can see how people handle the blood products, that they make it a priority to ensure that the blood products are always almost concierged into a clinical area, that there's a lot of care. You can see that people actually are physically caring for those blood products and want to be sure that they're not left out of their sight, that they get to where they're intended to go, that we monitor really carefully any person who's receiving them for any adverse effects, and properly recorded. I see people diligent about writing on the bags and recording what is being given and when it's being given, versus people that might be in a hurry. I think it's that slowness, that reverence that people take, that this is what's needed at this clinical time.
It's almost like hasten slowly, isn't it, where you slow things down and do them thoroughly. Pauline, it seems like you might have had some experience with...
After my failed transplant, they were doing plasma replacement at PA. And yes, the person doing that, taking the stuff out and recording numbers and saying, what we don't use by such and such, we need to get back. And, it was all done very, very carefully. Yeah.
Seems like a real issue of respect that's coming through from both of you. It's very interesting.
Well, it's precious. If people are going to go and donate their blood, it's what is then done with that blood that will show that person come back and donate again and again and again. And, if they're not treated properly back there, you lose it.
I'm interested. It's almost like, I wonder if there's some connection. We have precious resource, we have finite resources in a lot of areas, and I wonder if there's like a consistency with people who appreciate finite resource and, our earth and our environment. And it's a bit of a tangent, but I think it kind of relates where we respect things that aren't infinite in their source. Liz, I'm curious about the process of short notice accreditation and whether or not you think I should disclose that I have a background in human factors, so probably more of a safety 2 kind of orientated approach to things. I also appreciate the need to do quality control and understand where our systems and processes are working well and where perhaps they need more attention from a systems point of view to modify and adjust them. I'm curious to know whether or not you think that sense that you've both described about moving into a clinical area that has that difference in almost approach to blood product management, whether or not you think through the process of accreditation that we can adequately capture that.
Yeah, and having to think about this really carefully, it's really easy to get carried away with policies and procedures and really throwing up lots of information and confusing individuals about all of the standards and all of the things that you need to do. Because if you actually read it from start to finish, it really is an exhausting read, and I think that's not what we want to do for accreditation. I think the most important thing that people can realise is that the point of each standard is to ensure that we have given the topic appropriate amounts of attention, and that we take it really seriously, because it's important to our patients' lives and it's important to an efficient and effective health service. But simple things that you need to know is there's going to be policies and procedures. There's going to be guidelines. You don't have to know them off by heart, but you do need to know they exist and where to find them, and that they apply to you. And that's really what I expect every clinician to know, and really every clinical support person to know, and every patient to know, that they need the reassurance that we've got those policies and procedures and guidelines freely available for anyone to access, and that it's no big deal if you have to pull it out and read it before you make a prescription. That's okay.
That's good to know. Yeah.
It's better to take that extra few minutes just to have a read of something than do something and then find out later you did it incorrectly.
Yeah. It has big consequences, I imagine.
It does, yeah.
Yeah. So Liz, what are the things that, I mean, it sounds like it's quite overwhelming for something to prepare for. So what would your tips be, I guess, for people to help simplify that process? What are the kinds of things to look out for?
So for most people, I really would love, as long as they know that there's a standard about blood or blood products, if they just know that and then know there's policies and procedures to look for, that's really half the battle. The next thing is really to get a bit inspired about each standard, and if I can recommend to anybody is just take your time, maybe a week, to go through each standard, familiarise yourself just with the name of it. So the fact that there's 8 is a good way. It's a good place to start. Then just take one day, 10 minutes of one day to think and reflect on this standard. For clinicians, I would ask you to use that 10 minutes to review to see if you've got any mandatory training that's outstanding in relation to that standard. And then program when you're going to do that, because there are some things that you need to do annually or once in your life or once every couple of years, and just familiarise yourself with that. The other thing I think I'd love people to reflect on is how to partner with consumers, because blood wouldn't be required if there wasn't patients or consumers. And so to remember that it's not just a clinician's role to know what to do when, it's actually our role to describe to patients what might be required in their life and give them the information that they need to make the decisions that actually pertain to them. And so being comfortable talking about blood and blood products to patients is really that ultimate part of the standard.
Anything to add to that, Pauline?
No. I'm just trying to... Yeah.
That's okay. Yeah.
Just trying to think in terms of, from the patient side of it, a doctor who's well informed and knows what they're talking about actually is more comforting than one that's sort of saying this, maybe this, so a more confident approach and knowing what they're talking about, rather than sort of fluffing their way through.
I imagine you're very good at sort of picking up cues on little things in the way that the doctors communicate with you, or any of our clinicians communicate, just to look for those sort of sense of, am I safe with this person? Do they understand, what's at stake for me here?
I actually, unlike some people, the first thing I do when a doctor comes in to speak to me is I sort of take a quick glance at them to try and judge their mood as they're coming in, because sometimes someone's just been dealing with something really heavy and then they're walking into you and you can still see it's on their shoulders.
Oh, interesting.
And so from my point of view, I usually say, how you going? How's your day been? Or something, just to take a bit of that tension off the day and just look at clinicians as they're there to help me. They're not there to just dictate to me. So if you've got someone who comes in to help, yes.
That's so good. Yeah. Liz, what have you seen in terms of people in the process of accreditation, or the stories or experiences or things that you've heard anecdotally about, experiences in clinical areas during accreditation? I'm looking for horror stories, please.
So I think the classic horror story is that or you hear an accreditation's going on and you're a clinician getting about your business and you see the accreditors walking down the hallway. So you just whip into the treatment bay, or you whip into the loo, or you just want to avoid being held up. And I would actually encourage people not to do that. Be really confident that you do your job and you do your job well. Accreditors are not expecting you to know everything, but they are expecting you to take things seriously, and that if you don't know, that you'll go and look it up or check it up, or that you'll be able to suggest where you would normally escalate that to find it. So it's not, you don't have to know everything, but But you do have to know that you've got some obligations and you've got some accountabilities and responsibilities.
And Liz, in terms of the change to short notice accreditation, how do you think, because obviously we make these changes with the intention that they're going to improve practice and improve patient outcomes, how do you think the short notice part of accreditation will improve patient outcomes?
I think the major change from periodic, pretty much 3 to 4 yearly, depending on the cycle that you're in, really allows us to concentrate on ensuring at all times things like our policies and procedures are up to date, things like our training is up to date. And I think it started to really focus us on ensuring that the training is fit for purpose and not too annoying, because instead of just rushing to get it all done every 3 years when you're supposed to do it every 12 months. We actually have to take it seriously that people are doing this every 12 months and really question ourselves about, do you redo the whole training every 12 months, or do you have a refresher set of questionnaires to prove that you still retain the essential information, and that if you don't, then you can do a refresher training. So I think the good thing is that it's really starting to focus us on what's important and what needs to be done. And I'm also looking forward to, as the custodian of a lot of policies and procedures, which is my job, I'm looking forward to spreading those out so that they get renewed more frequently in that 3 yearly cycle, instead of all together just before the 3 years is up.